Thanks for staying with us. Now, just like the Ghana Post, the Ministry of Health wants to go paperless. What this means is that you don't need a hard copy folder to access healthcare. Everything will be done online. There's more on this new project that will be launched tomorrow. In this interview, Mamavi Owusu-Abuaje had with Dr. Anthony Nsiasare, who is Director General of the Ghana Health Service, and Thomas Mark Schofield, who is the Chief Technology Officer of the Lightwave e-Healthcare Solutions.
About the Ghana Health Service going paperless, and my guest Thomas Mark Schofield, his Chief Technology Officer with Lightwave e-Healthcare Solutions, and also Dr. Anthony Nsiasare, Director General of the Ghana Health Service. Good morning to you, gentlemen.
Good morning.
Let me start from home. So let me start with you, Doc. What are the challenges with the system as we have it today?
Good morning to all the viewers. The challenge you have of the system presently is that it's too much paperwork. You move from every point that you move. Somebody has to pull a paper out, write it, fill it, and that is what is happening. It's very inefficient. It doesn't make the health system very seamless and then very smooth. For example, if you are in a hospital, which are any hospital, if you are not very careful, and then you have a ENT problem, you go to the ENT department, they give you a folder and everything, and then for one reason or the other, about 2 days later, you have a problem which is surgical. Then you go to the general surgical unit, you also be given another folder, and then if you are a lady and then you also have pregnancy, you have to go to collect another folder. So one patient, within a matter of about 2-3 weeks or 1 month, has about 3 different folders. It means the system not.
But we've been living with this system for like forever.
We've been living with this system forever, but the current thinking of the Ministry of Health, Ghana Health Service, and for that matter, this government, is that we have to be paperless. We have to go digital. We are leveraging whatever we are doing in this in the health sector. We are taking advantage of information communication technology. So we want to, from the lowest level, which is the CHIP center, to the teaching hospital, to surveillance of disease in this country, we want to do everything digitally. And that is the support that we are getting from the central government. And we want to use health as an example to go digital. As we speak now, we have given mobile phones to even community health workers. Community health nurses are holding tablets. If you go to the sub-district level, the health information people are also using laptops. And we're aggregating all this data and then feed it into our district health information management system, which is a DIM system. So that we have a seamless flow of information. You know, information is very vital. If you want to take any decision, you don't have information readily available, it's going to be difficult. So this is what we are trying to do. And we thought about this thing by taking advantage of what is happening in this country. In this country, the penetration of mobile phones is about 127%, according to the latest NITA report that we read. About 37 million mobile phone users are in this country. So we take advantage of it. Almost every young person from the age about 6, everybody knows how to at least go on the mobile phone. There are people are text messaging, they are doing social media. So we are in health are taking advantage of this. For example, we have an adolescent health system where we can go to Google and do a Google Play and they interact on adolescent reproductive health. You teach the young lady that at a stage in your life, your systems will be changing. You'll be having menstruation. If you have menstruation, it's not an illness. If you have menstruation and you are not very careful and then you do unsafe sex, you can get pregnant. All these things, they do interaction. So we take advantage of that and teach them. We've put all these things also in pregnancy, and we are using mobile phones in the rural areas by the community health workers and community health officers to interact and then be an interface between the community and health system. So they go to houses. If you recently remember in September or so, when we went and then took over 6,000 mobile phones, which was donated by organization through Jeffrey Sachs Millennium Village Initiative. So we are now going to collect real-time data at the community level.
Okay.
Feed it into the sub-district level, and it will feed into district level, and it will feed into the national level. If you do all these things, and the hospitals don't have electronic medical record system, it means the hospitals will still be writing. But the hospitals, according to this project that we'll be launching tomorrow, we have taken 26 health facilities, from the CHIP center to the health center to the district hospital to the regional hospital and to the teaching hospital. We didn't even concentrate on only public health institutions. We are also concentrating on all the private health institutions. So we want to do this as a pilot, which has been successfully done, and tomorrow we'll launch it and then scale it up in the whole country. So it's a revolution. It's a paperless digital revolution that we want to do in health. It will bring two things. Somebody will tell me, oh, maybe it's too expensive. It is not. One, it will make the work very efficient. Two, we cut down waste. Because if you buy paper, you continuously be buying paper if you don't know where to store the records. And three, it will give the health workers also real-time information that they need. Now, if you are referred, immediately you are referred from maybe your hospital to Kolebu or to Komfanocho or to the higher center, your records are already there.
I want to bring Mr. Schofield in, because you've been working on the technological aspect of this whole project. You know the challenges that we have in Ghana. What is this system running on? Is it internet? Is it electricity? You've seen how our situation is. Can this really work in the long term?
Well, kind of ironically, the basis of your first question to Dr. Sari touches on exactly what we have learned. You ask, we've been paperless for so long, why now? Up until the last few years, the company or the country's infrastructure wouldn't really support this level of enhancement to the healthcare environment. So what has happened is with the cellular communication and the fiber backbones that are being installed, the connectivity is now stable enough to integrate hospitals and allow them to work together rather than act as silos. But one thing we did when we did the assessment last spring, we went around to each of the hospital facilities in the central region where we have deployed and evaluated their current level of technology acceptance and the infrastructure around them that would support such a project. It actually changed our original concept of what we thought we would be deploying, in that the infrastructure met a standard that we could deploy, but it isn't as robust as other developed countries. So we have made use of what is available. It does not use the internet, and I want to be very clear about that. It does use connectivity between sites, but it is called a private network, a private VLAN. It never touches the outside internet, as you know it. So the security around the health information that is being transported is at the highest industry standards available to execute. We are compliant, and the solution that's being deployed is compliant with all Ghana data protection laws. Lightwave, the company that is assisting the ministry with the deployment, is registered with the Ghana Data Protection Agency. And our architecture has been reviewed and evaluated. But even more so to that, our architecture is in compliance with international accepted health policy standards, which and like a HIPAA in the U.S. We are completely compliant, and the data is completely secured.
So practically, if I went to, say, my regular hospital, and let's put it at, say, La General Hospital, that's where I would go to. What do I have to do as a patient?
Once you have gone the first time and been registered into the system, the second visit you would just walk in and give them your name, your information. They would pull you up. Your record would automatically be pulled and made available.
So nobody's going to any storeroom to go and physically pull a folder.
No, your information is already available once you have been identified in the system. And then that record follows you throughout the entire encounter, whether you go to vitals, consult, lab, or the pharmacy, inpatient.
So what if I am referred to Kolebu from La General Hospital? What happens?
The systems are networked together that they can share patient information. So you can then, your information would be available. If you were in an accident that sent you to Kolebu, the doctor there, even though you were not able to speak for yourself, could in fact access your health information and make care decisions based on information rather than the current system, which is less portable.
And this has been tested.
It has been
and it works.
It works. It's been tested and it works. We are very excited about the launch tomorrow, where we actually get to show off the work that has been done. It is very powerful.
Dr. Nsiasare, how widely did we test this?
We've done these tests at the moment in Central Region, in 26 health institutions.
Okay.
Because if you do it in a region, not even one district, different districts in the region, and then the portability is there. Apart from this, there are other pilots which are being done in Ashanti region. The other pilots also being done, I think, somewhere in the Volta region by different organizations. So if we learn lessons from it, we are not doing this thing from the scratch. It happens in other countries, in other developed countries. So this is exactly what we are doing. But the most important thing about what tomorrow we'll be launching, we are also launching what we call biosurveillance. What it means is that we are also trying to do this disease surveillance so that when there's cholera, immediately the patient goes to the hospital, just from the symptoms alone, it will just give us a warning sign that in so and so hospital, there's a patient who has come there, the symptoms seems like cholera. Even before the stools are tested, we do the test. Then the disease control people will then be alerted and then move there. So there's an early warning signs before even the records are all integrated and then analyzed for people to use. So this is how we are going to do it. And we are doing this thing also is going to assist us to do teleconsultation and telemedicine. As I speak now, we have almost digitalized most of our X-rays. TB detection, we are using 48 digitalized X-rays of 2 mobile X-rays, which are all digitalized. So you don't need a radiologist even to sit at the center to have a look. It can be transmitted to the radiologist. The folder can be transmitted with all the pictures and then give the diagnosis and send it back to the institution. It helps also to bring quality care to the doorsteps of the community. So a community health worker or officer who is in a village is supported by specialists who is in the regional hospital or in the district hospital. That's the beauty of it. You can have a pregnant woman who will sit at a chip center. People go there with motorcycles, take the blood samples, check the blood, and then send it to the district hospital where the blood test will be done. And this results can be sent just by mere SMS message or WhatsApp message. And it's done in such a way that the patient doesn't have to move from wherever he or she seeks the first health service to another place. You have to write a request. He has to move. You don't know if he has even transportation costs or anything. And then go and sit down. They say, come for the results in 2 weeks. It will be no more. So that we just, within an hour, the patient can sit down there.
And this is effective when?
This tomorrow, when it's lunch, it means that those 26 areas are all effective. And we are doing pockets of it in other regions. For example, as I speak now, we have about 5 teleconsultation centers where nurses and midwives and doctors are there giving advice to the lower levels. We did a pilot in Amansia West, and Kumasi has it. I think Central Region has it. Tamale has about 6 of the regions have teleconsultation centers.
Okay.
And we hope by next year we do it for the 10 regions.
But do we have enough funds? We've started this. It sounds all well and nice and beautiful, but do we have the funds to see it through to the end so that the entire country is covered?
If we have funds, we have done the whole thing tomorrow. The whole country,
which means we don't have enough funds.
So we are.
Could we be locked up somewhere?
That's why we are doing it in phases. We won't be locked up anywhere, because you see, once you cut down waste, you can free some funds, prioritize it, and that's one of our priorities. I always say that if you don't have money, then you have to be very efficient. If you don't have money and you are inefficient, it is worse than somebody who has money and is throwing away. So we will prioritize. You see, funds will never be sufficient, but funds will be sufficient for prioritized projects. And that's exactly what we are doing in health sector.
Okay.
And we continue to prioritize and put where money is supposed to go to achieve the results that we need. And this is exactly what we are doing. We believe that digitalizing our health system would make the work efficient. It will free some funds, unnecessary funds which are being wasted, and then we can deploy it into other sectors, and then we have a seamless quality care. What I'm thinking of is that by 2030, we will only have universal health coverage. But I always qualified, but we will have quality universal health coverage.
2030.
2030.
Okay, Mr. Schofield, what if there's a blackout in a facility where I have visited? What happens?
Power is on our risk log as an opportunity. We are working with the Ghana Health Service teams to develop strategies at each level of need for power. The larger facilities, hospitals, most of them have generators. They've had them since the inception because of the criticality of operations and things like that. So it is the health centers and the clinics, the chips, that we have to kind of manage the power expectations. And through that, we are working with teams with the Ghana Health Service. There are recommendations for both solar and generator depending on scale. So there is opportunities there, but for right now, the system is very viable as it is functioning. In the hospitals, it functions virtually all the time. In the health centers, they do suffer, but we are looking at ways to minimize that impact.
Finally, Doc, how much is this costing us as a nation, and who is paying for it?
The Ghana taxpayer is paying for it. At the moment, I think this one costed, what's the initial cost? I have to check it. I don't want to give a figure which I'm not sure of. But this is all from Ghana government tax. We wish that we get also some development partners to support. Most of them are very interested, and I think after tomorrow we may have one or two of them coming to assist so that we can redeploy it in all the other regions. But at the moment, it's purely Ghana government funded.
All right, so we wait for the full launch tomorrow, Tuesday, but I thank you for your time this morning. So my guest, Thomas Max Schofield, Chief Technology Officer, Lightwave eHealth Care Solutions, and also the Director General of the Ghana Health Service, Dr. Anthony Nsiasare.